Good afternoon, everyone, and welcome to today's webinar entitled Ethical Issues in Living Donor Transplantation, ranging from kidneys to uteri. We're so glad that you could join us today as we have a wonderful presentation in store for you. My name is Deanna Fenton, and I am the Program Coordinator for the Alliance. Now, we have just a few logistical items to review before we begin today's presentation. For those of you who have never joined us on this platform before, the chat feature is located in the bottom left-hand corner of your screen. Now, we are recording this webinar, so we will not be opening the phone lines during today's presentation. That means that all questions must be submitted electronically using this chat feature. If you have any questions that come up during the webinar, please feel free to submit them at any time. Once the presentation is complete, we'll allow some time for our presenter to address as many of your questions as time allows. Registration is currently open for our next webinar entitled Emergency, How to Prepare and Meet Regulatory Requirements. That's coming your way on October 9th at 2 p.m. Eastern. Registration is also open for our upcoming webinar entitled Penile Transplantation, Restoring Confidence and Identity. That's coming your way on October 17th at 2 p.m. Eastern. Now, we are offering continuing education credits for today's presentation. For those of you who may be interested, we are offering one CEP-C credit and one nursing contact hour, courtesy of Iowa Donor Network. Everyone listening to today's webinar is entitled to claim these credits. If you're listening in a group, as many of you are, please make sure to get the evaluation email from your group lead. It's a very brief online evaluation which will allow you to receive your credit. As a reminder, for nursing, you have 14 days to claim your credits, and for CEP-C, you have 30 calendar days. Now, at this point in time, I'd like to introduce our moderator, Savitha Iyengar, Manager of Quality and Compliance at Mayo Clinic St. Mary's Hospital. Savitha, we're so glad that you can join us today, and at this point, I'd like to turn it over to you to introduce our speaker.
Okay. Thank you, Diana. It's my pleasure today to welcome Dr. Reid to be our speaker. Dr. Reid is the Chair of Transplant Ethics Advisory Board at Mayo Clinic Rochester. Dr. Reid is embedded in the Transplant Medicine Center, where he provides ethical analysis regarding morally challenging issues related to transplant medicine. Dr. Reid holds a graduate degree in medical ethics from the Medical College of Wisconsin. In addition to his role in transplant medical ethics, Dr. Reid diagnoses and manages chronic orofacial pain. His research focus is on ethical issues related to the diagnosis and management of chronic pain. Dr. Reid has been on the staff at Mayo Clinic Rochester for 23 years. He previously served as the chairperson of the Department of Dental Specialties and has held numerous other roles both within the department and external to the Department of Dental Specialties. Dr. Reid?
Thank you so much for inviting me to participate in this meeting. I'm excited about this. I hope that none of you will be disillusioned or disappointed to know that this is not my painting here. This was done in the 16th century. That's not my painting. This is what I'm talking about here. So let's begin. Maybe I should use this. Let's begin. I have no disclosures. The opinions that I state today are my own. They're not my employer's, nor are they any of my colleagues' opinions. So a military guy who was in the Navy was about to be deployed in the months ahead when he and his mother presented to a transplant center interested in having him serve as a donor for his mother, who was dialysis dependent. They were not a biologic match, and therefore he clearly was not a candidate to be her donor. And they had discussions then about a chain. And what emerged from that discussion was the potential for him to participate in what is referred to as a short-term unmatched donation, in which he would donate prior to deployment. And in fact, this is what happened. And fortunately, 5 months later, his mother received a kidney to bring the whole issue to full circle. So things worked out well for this donor. However, you can imagine under many circumstances how it might have gone awry. And this is one example of one of the situations that I would like to talk about a little bit later with regard to some of the ethical issues that come to bear on the new advanced donation programs. Now let's turn our attention to another case. This is in reference to a father-daughter pair. The father is the intended recipient with end-stage renal disease. He's had a long-standing history of alcohol dependency and has been sober for 1 year after 2 inpatient treatments. He is a CEO of a big business in the tech industry and is wealthy, a multimillionaire. He's divorced, remarried, and his wife actually called the transplant center to say that, quote, his daughter will donate. The daughter is 19 years old. She is a college student at an Ivy League school in New England. She has aspirations to attend law school or maybe a different graduate school. She would like to donate during spring break. She mentions throughout her assessment that she is keenly inspired by motherhood, and she wants to have several children. She identifies herself as a peacekeeper among her family, and particularly in the triad of her mother and father and stepmother, the dynamics of which could be characterized as an adversarial relationship. So the question is, relates to whether or not this live donor should be permitted to donate under these very compelling conditions. And we look now at some of the issues that come to bear on this situation and begin to have a sense about the tension between respecting her autonomy and her desire to donate pitted against our own obligations to protect her and to avoid doing harm when we can. So under these conditions, we see that if we support her donation, we must be comfortable that she's not under undue pressure to provide this kidney. We must help her understand that this donation may have a significant influence not only on her current schoolwork, but perhaps even on future schoolwork in graduate school. We should ask, too, and we should gain her understanding about whether she sees or understands that there could be significant repercussions in terms of her own aspirations to motherhood or to reproduction. We must also take into consideration the issues of family dynamics if she doesn't donate and how they may be influenced if indeed she does donate. We are further compelled to consider whether or not this 19-year-old woman actually has neurological or neurocognitive capacity to make the decision to proceed. This is not to challenge her capacity with respect to schoolwork or financial issues or interpersonal relationships or other abilities, but rather this very specific issue with regard to capacity to make a decision to donate a kidney under these circumstances and in this context. So you'll notice that I don't have any answers at the moment, and I may not at all, but what I would like to do is set the stage for consideration of these cases a little bit later as we go through this talk. So the core issues in transplant ethics typically relate to defining death, which continues to be a significant discourse in the literature, the procurement of organs, and also the allocation of organs. But for our purposes today, a primary interest is in the organ source. So transplantation is unlike any other part of medicine, really, in that for every recipient, there must be an organ source or a donor. It's unlike any other area of advanced medicine in that way. And specifically, we hope that someone will die or sacrifice substantially in order to be able to provide an organ for others. Now, that is a little bit of maybe an oblique way to say this, but we depend on someone's death or the sacrifice of another in order for transplantation medicine to thrive. And we're actually also hopeful, for example, with respect to kidneys, that we have a live donor as opposed to a deceased donor, because living donor kidneys last longer. We also know that the younger the kidney, the more likely it is to last longer. So in a sort of an uncomfortable statement, we might say that we hope that that someone who is young is willing to make very significant and compelling sacrifices in order for transplant medicine, and in this case particularly with kidney donation, to proceed successfully. So the ethics of living donation are very complex, as everyone in this audience knows, and they involve a whole host of issues, some of which are listed here, and I'm sure that the audience could add many more. But when it comes to live donation, we need to understand whether this person has been paid, if this is an altruistic donation, directed versus non-directed, if this person is healthy or unhealthy, whether they're naive or wise, whether they've been manipulated, pressured, if they're at risk for other reasons of which we're unaware, or if this is a volitional overture on their part. This is extraordinarily important when it comes to our obligations to protect people, and that is to avoid doing harm when at all possible. And this is also in light of our obligations to respect the autonomous wishes of individuals who want to come forward and make altruistic overtures to donate to loved ones and actually to people they don't know. So the tension is set up from the get-go, really. Live donation isn't going anywhere. As we can see here, to date, this year, deceased and living donation is close. 44% of all kidney donors are live donors, and 56% are deceased. As you can see, the numbers are similar over the past 2 years, and which clearly means that living donation is here to stay until something more novel comes along. This means that we must be comfortable with our obligation to non-maleficence as an enterprise. Transplant medicine must have reached the point at which it is at peace with its obligation to avoid harm when possible. This is not the same as do no harm. Non-maleficence makes reference to our obligation to avoid harm when possible, and clearly, in this case of living donation, we must be comfortable that the harm we're doing is essentially worth it in the context of transplant. When we talk about harm, I believe we have to look at this in a broad context, not just physical or medical harm, but we also have to understand that harm can come in many stripes, including emotional, psychological, economic, recreational, familial, reproductive harms, and that we must feel like these harms or these risks of harms are justified. We have to believe that they're justified if living donation is to proceed in a successful way. And we also have to understand, I believe, that justification doesn't just fall from the sky. If we say that something is justified, it is in our best interest to be able to articulate the reasons for which we believe it's justified using language that is rooted or grounded in ethics, rather than to make statements like this that are simply emotive or based on our own biases or our very own personal moral framework. We often talk about risk, and this is an important concept because I believe we have to operationally define risk under these circumstances, under the circumstances of transplant. If I had a severe facial deformity that negatively influenced my life in terms of social, occupational, recreational, educational, interpersonal relationships and activities, my sense of risk is likely to be very different from someone who's writing an article about the risks of immunosuppression and vascular composite allograft. We have a very different perspective. And I think it's important when it comes to ethical consideration of these issues that we take that concept into consideration and talk about it in terms that are rooted not so much in emotive and hyperbolic sort of psychological language, but more in line with ethical tools, which is what I want to talk about most in the moments ahead. For now, it's important to emphasize that live donation involves two people, that is, two patients, each of whom has equal moral worth. There is no hierarchy in transplant medicine, and that is the recipient and the donor, live donor, have equal moral worth. So our obligations, our moral obligations, are doubled under these circumstances, which requires a great deal of discussion, discourse, commiseration among members of the team. For example, we know that if people come to centers as non-directed donors, it's our obligation to consider whether or not this represents some sort of radical altruism, or if they're motivated by factors that might make them less, might make their capacity less than what we would hope it would be in terms of making a decision to donate. Directed donation is in some ways quite similar to being paid to donate or to sell a kidney, in the sense that there can be a tremendous amount of pressure from family on individuals to donate. And so those are things that are important to abstract from the assessments and during a donor recipient's assessment. And similarly, in paired kidney chains, we know that while recipients are eagerly awaiting a kidney, we know that donors may feel a tremendous sense of pressure to donate, knowing that the chain is dependent on their participation, making it difficult for them to remove themselves or to forego participation should they wish to do so. There is also the issue related to knowing that if they do, knowing that their intended recipient may receive an organ that is less pristine than their 25 or 28-year-old kidney. And this comes to bear on the psychological risks that are associated with living donation as well. So let's have a look at this. Let's think about this person who's about to donate for uterine transplantation. The intended recipient is a 31-year-old woman with 4 adopted children. The mother, who is 62 years old, who's had 2 children, has agreed to donate. Now, we know that the majority of attention seems to be directed toward the mother, who wishes for a consanguineous offspring. But we also know, based on a good bit of literature, that there is significant risk that comes to bear on this sort of donation. And it is incumbent upon us to take into consideration whether or not participating in her donation is consistent with our obligation to avoid harm when possible, and other principles that I'll discuss in a few moments. Here you can see a timeline of uterine transplantation that begins on top there with in vitro fertilization, followed by, in this case, the mother's hysterectomy. And then we lose sight of the mother. There's immunosuppression, followed by transplantation with the recipient, followed by, if things go well, pregnancy, followed by C-section. If that goes well, followed by another successful pregnancy, and then another C-section, and then hysterectomy if the patient agrees to hysterectomy, which we assume that they would. Now, way back on the left here is the person who's had this hysterectomy, and that hysterectomy could very well result in some adverse consequences for this donor. And we must ask ourselves, in the big picture, in the context of uterine transplantation, whether or not we should be participating in this risk in this type of risk. Now, I should say that as an ethicist, my role is not to tell you, but is to present questions. So many of my questions may sound rhetorical, but they're not. They truly are genuine questions. We know that the numbers of organs donated in 2017 still come primarily from deceased donors. But we also know that the numbers of deceased and living donors, not organs, donors, are converging. So once again, I just want to emphasize that living donors will continue to be a very substantial part of transplant medicine, and the ethical issues that come to bear on their donation will only become more and more difficult and nuanced as technology proceeds and progresses as well. So let's look at another donor and call this guy a complex donor. This fellow is a 36-year-old male who is a medically suitable donor for his intended recipient, who is his cousin. His history, the donor history, is complex. He has bipolar disorder. He's been hospitalized twice, the most recent of which was about 1 year ago. He has a very erratic job history, which has been influenced by chemical dependency, which has resulted in a couple of DUI arrests, again, the most recent of which was about 1.5 years ago. He's currently enrolled in a government program with job that gives him an opportunity to study for a job, and so he's in school and he's working at the same time, and things have been stable for about the past 6 months or so. During his assessment, he routinely remarks that he feels as though this is his opportunity to make amends for all of the troubles that he's caused his family over the previous years. He repeatedly says, "This is my chance to make up for all the troubles and all the heartache that I've caused my family. I really want to do this. Please let me do this." So now we're faced again with a very significant overture with regard to respect for his autonomy. He wants to do this, but this is in tension with many of our obligations that, again, I'll articulate and describe a little bit more as we go. So suffice to say that it's my opinion that the moral core of transplant medicine relates to the source of organs. That's not to say that the other issues are not important, but from my perspective, the moral core is related, especially when it comes to living donation, to the organ sources. Now, I'd like to challenge you to think about something if that's the case. If I could poll everyone in the audience, I would ask you if you believe that it's intrinsically good to save lives. My guess is that most of you would say, yes, it's intrinsically good to save lives. Then I would tell you, and we would likely agree with this fact, if we had more organs, we would save more lives. So it's intrinsically good to save lives, and if we had more organs, we would save more lives. In a previous administration, this was very important. You can see an advertisement that says just one organ donor can save 8 lives. So I'll state this again. It's intrinsically important to save lives. If we had more organs, we would save more lives. And as a result, we would increase the life expectancy of everyone, most everyone in our population. Therefore, we should consider implementing a survival lottery. Now, a survival lottery means that the federal government would oversee a program where episodically a healthy individual would be chosen to donate or to provide as an organ source. I shouldn't say donate. Would provide at least 8 organs. This person would be chosen randomly. They would be placed under general anesthesia. the proximate cause of death would be the removal of their organs, and in doing so, we would meet the prior premises and facts that I stated. It's intrinsically good to save lives. More organs would save more lives. We would increase the life expectancy of virtually all of the population. And in fact, the person that is chosen, the people that are ultimately chosen, have a far greater percentage, a far greater probability of encountering organ failure and the prolonged disease and discomfort resulting perhaps in transplantation. So their chances of being chosen are far less than their chances of becoming ill and undergoing prolonged organ failure. Now, no one, and I can assure you, based on the stares I'm feeling in this room, no one would agree with that. I certainly wouldn't, and neither would you. However, it's not okay, from my perspective, to simply blurt out, "That's unethical. That's wrong." We need to do better than that. We need to speak in language that defines our support or our lack of support to ethical issues in more articulate, more convincing ways that add to the discourse and remove the elements of emotion and bias and presumption, because that leads to a much more effective conversation. And of course, I'm revealing my own bias here that leads to a much more effective conversation. And I'll show you what I mean in a moment. But I would like to discourage this sort of language. That's unethical means nothing. In a pluralistic society, in a morally pluralistic society, what I think is amoral or unethical is not necessarily what you think is amoral or unethical. And in medicine, because of our shared obligations to do good for patients, to avoid harming patients, to respect their autonomy, we need a common language. That's what I want to talk about today. So, over the decades, centuries ago, and even today, there have been essentially two moral theories that have been very popular. The one on the left is referred to as deontology. This is a rules-based moral theory. This moral theory states that decisions that we make and behaviors that we undertake are morally justified regardless of the consequences. This is a rule-based that was developed by Immanuel Kant centuries ago. And essentially what it amounts to is that you would do the same thing under the same circumstances, under all similar conditions forever. So you don't kill, ever. You don't lie, ever. So when you're hiding a group of political prisoners in your basement and the bad guys come to your door and they ask, "Are you hiding political prisoners in your basement?" the answer is yes, if you're a firm deontologist. You can imagine that it would be very difficult to construct a medical ethics practice under these conditions. On the other hand, what you see is utilitarianism. We all know about this. This is the greatest good for the greatest number. This is also a theory. And so John Stuart Mill, a few centuries back, attempted to develop a very nuanced calculation of utilitarianism such that we could decide whether actions or decisions were morally justified if they met the criteria of utilitarianism, and essentially that is the greatest good for the greatest number. So, under these conditions, we might say that all people in the Midwest who are 5 feet 6 inches tall, who have type 1 diabetes, are much more likely to be compliant with the use of insulin. Therefore, most of the insulin, if not all of it that's available in the United States, should be shunted toward this group because they're better at taking it, they're more compliant, and therefore they have more positive outcomes, which result in far fewer dollars being spent on adverse effects of not using insulin. said no one ever. This is sort of like the survival lottery. No one would agree to this, but this is what a utilitarian calculus would lead us to. Now this is, by the way, Kentucky is in my home state. This is these are thoroughbred horse paddocks. You'll notice that the fence lines don't converge. They just go on and on forever. And similarly, deontology and utilitarianism do not converge. But note the tree in the middle. I'll come back to that in a few minutes. Now, as a result, medical ethics has developed a number of tools. All of these tools have their place in medical ethics. But the one I want to talk about today primarily is principlism. Now, principlism was developed by Tom Beecham and James Childress. Most of you have heard of this. This is a very prominent, popular medical ethics tool. And what I would like to emphasize straight out of the chute here is that among these four principles, there is no hierarchy. So I'll state them. Beneficence, respect for autonomy, non-maleficence, and justice. Or we could state them differently. Justice, non-maleficence, respect for autonomy, and whatever it is I left out. So there are four of them there. None of them take precedence in any particular circumstance. Let me state, too, that we, all of us, who are licensed healthcare providers of any sort, have a fiduciary obligation to honor respect for patient autonomy or autonomy, beneficence, non-maleficence, and justice. We are obligated from an ethical and sometimes legal perspective to honor these obligations. So let's look at them more closely. These are basic principles. They are not theories. They are derived from the common morality, that is, common morals that people share in societies that are committed to common morals, such as help the needy, protect the vulnerable, don't kill people, and so on. These moral principles provide an analytic framework. These moral principles they provide a tool. They're a lens through which we can see, perceive, and have a discourse about transplant ethics issues. So essentially, they are a sort of feather bed to fall on when we're discussing extremely complex issues that are difficult to resolve. These are starting points in biomedical ethics. Let me emphasize, however, that there will always be moral residue when we make transplant ethics decisions, or for that matter, any medical ethics decision that requires this level of discourse and analysis. So we'll always be able to make some decision to go this way, but we'll always be wondering if we really should have gone that way. There are no hard and fast right answers, usually. We'll come back around to that in a minute. So now let's look at beneficence. This is one of the principles. It is not the first principle. Keep in mind there is no hierarchy. Beneficence means that we have an obligation, a fiduciary obligation, to take positive steps to help others, to protect and defend the rights of others. It's important to see that beneficence, because of our obligation to beneficence, we should rescue persons in danger. We should prevent harm. We should help people with disabilities and remove conditions that might cause harm. This is beneficence. This is essentially why most of us enter into healthcare work. Now, let's look at autonomy. Autonomy makes reference to an individual's ability to make decisions by self-rule or self-governance. To say that one has autonomy means that someone can make a decision, and that decision has been made free of controlling interference. Is the daughter free of controlling interference in the earlier case? I don't know. Is the mother? We don't know. But if they're not, then they do not have autonomy. That is, they are not making a decision based on their autonomy. If someone does not have a good, thorough understanding based on our efforts at informed consent, then they are not making an autonomous decision. Respect for autonomy is less about the liability of treating people and more about facilitating the understanding of patients to make decisions rooted in their own preferences and values, not ours. In order to make decisions, autonomous decisions, one must be independent from controlling influences. That is to say, one must have liberty. In addition, people must have agency. If we are to say that they are making autonomous decisions, they must have the capacity for intentional action. Now, I'll distinguish this a little bit from respect for autonomy. Our obligation to respect autonomy means that we have an obligation to act. This is an action-based principle. Our role is to build capacity for autonomy, and that's where informed consent is born. Informed consent is often perceived as a piece of paper that we put in front of someone and have them read it, which they don't read, we know that, and sign it, and we then feel as though our liability has been covered. In reality, informed consent is a process of inquiry, talkback, probing, and so on and so forth, in the context of a person's perceived ability to understand what is about to happen to them. So respect for autonomy is an important obligation that we have, as is non-maleficence. Now, non-maleficence means that we have an obligation to avoid inflicting harm, and that we must refrain from harmful actions, that we should avoid thwarting the interests of others. Think about that medically complex patient for a moment. Should we thwart his interests? Should we thwart the interests of the daughter who wants to donate to her father? We should avoid imposing risks of harm, however. That's another part of non-maleficence. Now, if there were a hierarchy, and if non-maleficence were at the top of that hierarchy, transplant medicine is out of business completely, because we do harm living donors. There's no question. It just depends on whether our harm is justified if in the context of transplantation. Distributive justice is essentially decided in the legislation and in hospital administrations. So this makes reference to the allocation of scarce resources, which should not be done at the bedside, though as the years go by, it's done more and more at bedside. But it's typically not something that's undertaken at the bedside. When it comes to transplant medicine, however, this is an integral part of all of our consideration about how we should go about allocating these very scarce resources. Now back to Kentucky here. So you see these two theories, deontology on the left and utilitarianism on the right. If you can agree that these are not likely to provide the practical framework that we need under the very complicated circumstances of transplant ethics, then I'm going to add principlism here. Now, principlism, again, is comprised of those four principles that are rooted in common morality. And if you would, think about the roots of that tree. I know that in the Midwest we say roots, but I'm going to say roots because that's Kentucky. So you can think about principlism as being deeply rooted, and that tree as being part of the principlism, sort of branching out into both areas of utilitarianism and deontology, as well as other moral theories. Remember that this is a framework. It's the beginning of an analysis of individual circumstances. It will never render an exact right answer. This isn't a vending machine. And there will always be moral residue once a decision is made. But we weigh and balance principlism. We weigh and balance all of these principles in each context, such that we make a decision about whether we are meeting our obligations to beneficence, non-maleficence, respect for autonomy and justice. And we discuss it in those terms that are mostly free of emotion, hyperbole, bias, and so on. So we weigh them, balance them, specify them. We frame our discussions about medical ethics issues around that tool of principlism. Now, on occasion, one of these will rise to a degree of prima facie obligation. What that means is that one of them will rise to the top quickly, and we'll all know it. So if you're an emergency department physician or nurse, and someone with meningitis comes to the ER and they're febrile and they're combative and they refuse to be treated and they're tough to get along with, we have an obligation to beneficence. And that obligation to beneficence takes priority. And so that becomes a prima facie obligation beyond any of the other obligations within the four principles. Keep in mind that there will always be tension among beneficence, non-maleficence, and autonomy. And what that means is that there will always be moral residue. There isn't an exact answer that emerges from this weigh and balance exercise. Note that justice has not been included here, but it's becoming more and more of an issue, and it's particularly an issue with in transplantation. It's always hovering in the background, to be sure. So let's go back to the father-daughter, and let's have a look at this. And I'm hopeful that we might be able to discuss this case and the others when we're done here. So the risks to the daughter have been articulated, at least in this paper, and there are others. There are risks, even though they're low, that she could develop kidney disease in the remaining kidney over the years. She certainly could encounter reproductive dysfunction. There could be psychological and emotional adverse consequences for her down the road. Now, if we were in a seminar room, I would ask you, what do you think the others are? And what I know that somebody would say is that this has the potential to have a significant impact on her familial interaction. If she doesn't donate, what's to happen with her tuition, her car, her house that her dad bought, the relationship among her mother, her stepfather, and so on. So this is a very compelling set of circumstances that we need to take into consideration, especially in light of the fact that she may or may not have the neurological capacity to make a decision, this particular decision, about what may happen to her many years down the road. So let's have a look at how we might approach this. Now, you can ignore the recipient here. We're just talking about live donation. So let's assume that we allow her to donate. We should ask ourselves the question, are we meeting our obligations to beneficence? And remember that beneficence is our obligation to do good, to protect people from harm. And in my view, and I want to underscore, highlight, embolden, this is just my view, this isn't the right view, but I am equivocal when it comes to whether or not we're meeting our obligations to do good under these circumstances. I am very concerned that if we were just to focus on her autonomous, or what we think might be her autonomous decision or her desire to donate, we may miss the boat. We may put her in a situation that is extraordinarily precarious. And by that I mean because of her potential reproductive dysfunction, the issues that may come to bear on her family dysfunction, on the interference with school, and I failed to point this out earlier, but no other donors have been considered under this circumstance, or in this particular case. I asked too, are we meeting our obligations to non-maleficence if we allow her to donate. You can see I was a little bit more assertive here. My view is that we're not. My view is that we are not meeting our obligations to avoid harm when possible. Now you can see there's a tiny little plus sign over there. The minus plus there is a reflection, a manifestation of moral residue. But as I weigh and balance these principles in this particular scenario, it's my assessment that we do more harm for this woman than we do good, and that's the reason I have an emboldened or a bold negative sign there. Now, the question here is not whether we are respecting her autonomy, but whether she is making an autonomous decision. And in my view, I think there's significant questions about whether she is or whether she even can be, given the circumstances. Her father pays for her house that he bought in New England when she became a freshman in college. He pays for her tuition. He will pay for her graduate school. He buys her a new car every year since she was 16. She mediates the relationships among the family or within the family. My concern is that there could be a tremendous amount of pressure on her and that it's questionable about whether or not she's making an autonomous decision. In this room, if we were discussing this, this is how I would present this if everyone agreed to take this sort of approach. Let's look at the uterine transplantation. So the risks to uterine transplantation, the risks to the donor are not insignificant. By the way, this paper is written by Bethany Bruno, who was a student here in the Transplant Center for a while. She's in medical school at Cleveland Clinic at Case Western. It's a brilliant paper that addresses whether or not uterine transplant should be done with deceased or live donors. So the donor risks can be significant in terms of their surgical outcomes. Quality of life could therefore be substantially adversely affected. Sexual dysfunction and psychological and emotional issues can occur as a result of this as well. Keep in mind that the hysterectomy for the mother is not simple. It's much more complex than the typical hysterectomy that many women will undergo in this country. So there are significant donor risks. Now let's have a look here and see, are we meeting our obligations to beneficence if we agree to let her donate or if we facilitate her donation? Here, my assessment was that we are, that she's a 62-year-old woman and that our process has been complex and thorough and comprehensive, and I believe that we are doing good in the sense that she wants to donate to her daughter, and that in the big context, her family would probably benefit more than they would lose by her donation. Are we meeting our obligations to avoid harming her? So I changed the weight of that plus sign and that minus sign probably 20 times before this talk. Right now, it's a little more positive than it is negative. That is, I do believe we're meeting our obligations to non-maleficence, though I can imagine that someone would argue this vehemently. Are we meeting our obligations to respect autonomy? I believe we are. She understands what the outcomes are. She understands at least the best we know what the outcomes are. So in my view, I believe it would be reasonable to proceed. But there are other really good arguments to the contrary, and it would be interesting and good to hear those. Now, when it comes to complex donors, we know that there is an enormous amount of stress, potential loss of income, and so on. You can see much of this here. What happens to this person emotionally and psychologically if the graft fails? And we can proceed here. I'm sorry. There we go. We can consider whether or not someone should proceed with this paired donation. With this complex donor. Forgive me. This was in reference to the complex donor. And I'm going to show this once more. This is the complex donor, the effects of stress, and so on. I believe that we would fail, we would abdicate our obligations to beneficence, non-maleficence, and autonomy by allowing this fellow to proceed with donation. I don't believe that we would be doing him much good. I believe we would expose him to unnecessary harms that could be avoided. And I'm not convinced that he's necessarily making an autonomous decision. Finally, I want to talk briefly about kidney pair donations, these innovations. The innovations that I've made reference to earlier are not showing up here. They are out-of-sequence donation, which essentially a donor donates into a chain early because of time constraints, and the paired recipient receives a kidney a short time later. So the donor is making a calculated risk that a non-directed donor would eventually donate. We talked about the second one, which is a short-term unmatched donation for the fellow that was going to be deployed. And then finally, a voucher. This person donates a kidney to receive credit for a named relative or a friend to be transplanted in the future. Now, one of the issues that comes to bear, or many of the issues that come to bear on these situations ethically are in the bullets here. We have to understand, the patients have to understand the management of uncertainty and the extent of donor and recipient consent, and the scope of obligation that the organization assumes. Some say there should be legal contracts. Okay, so I've touched base on some of these. I want to thank you for this whirlwind talk about living donor ethics. Thank you very much.
Thank you so much, Dr. Reid, for this insightful presentation. Before I turn it back to Savitha for questions, just a reminder to everyone listening in, if you do have any questions for our presenter, please be sure to submit them using that chat feature that's located in the bottom left-hand corner of your screen. Also, I would like to note during the Q&A session, I will have this poll up. For those of you who are listening in a group, please complete this poll and let us know how many people were actually listening in. And with that, I'd like to turn it back over to Savitha to moderate your questions.
Thank you, Dana. One question for you, Dr. Reid, is it would seem in this whole process that we have to respect the donor's wishes. But in respecting a donor's autonomy, that should take precedence over everything else. Are we being paternalistic to tell somebody, you don't know what's best for you, so you can't donate?
Well, to some degree, we are being paternalistic, and that's always a tough intersection. We do have professional autonomy. We have as much autonomy as professionals as patients have autonomy as patients. And although we would like to be able to acknowledge the wishes and desires of patients at every turn, we also have obligations to protect them from harms from which we can protect them. And so while some would vehemently argue that to deny, for example, the medically complex donor the opportunity to donate, some would say that we are interfering with his autonomy. Others, and I included, would say that we have a greater obligation in a bigger context within the aims of medicine to protect this fellow, given all of the issues that he brings to the table. It could be that he could donate 6 months later or a year later. But for now, I believe that while there are those that would accuse us of being paternalistic, I believe there's a better approach to that, a better look at it, and that is we are being comprehensive and we are being compassionate, and we are doing so within the context of the principles that I outlined there.
Thank you. Another question is, in the same context of that cousin who wants to donate, is it possible that being able to donate would give some kind of closure for him to have a chance of doing good, turning his life around? Would that be more meaningful?
To be sure, there's the moral residue. That's it, right there. If we decide that we feel like it would be too dangerous for him to donate, that is, if we feel like we would be exposing him to harms that we could avoid, or he could avoid, or that, well, you understand, that we could avoid, then we have an obligation to protect him. On the other hand, it could very well be that donating to his cousin would be a seminal event in his life that would literally be the starting block for him. Thus, we must weigh and balance all of the potential outcomes within our ability. In selection committee meetings and donor meetings, a strong advocate for the recipient might very emotively and if not assertively say, look, this guy wants to donate, he's an adult, he understands what's happening, he's a perfect match for my recipient, we should do this. That shuts the dynamics down. That creates a dynamic within meetings that are extraordinarily difficult to overcome. So my plea is that we make that discussion we revolve that discussion around principles, around ethics language, rather than that emotive power differential.
We have one final question probably before we close today. What are the ethical implications for allowing a prisoner to donate to a family member?
Oh, we just about got out before that one. Yeah, so the ethical implications are broad. So a prisoner loses autonomy by definition. A prisoner loses autonomy. So someone who is in prison does not have the capacity to make decisions because they have lost their autonomy. They have also lost, but they are also incompetent, which is a legal term. They do not have the competency to make that sort of decision. There are many who would turn red at this answer. So the fact is that because they have lost autonomy and they are so vulnerable as a result, we have elected to forego their ability to donate organs. There are many that would argue that prisoners may represent a tremendous source of organs, similar maybe to the survival lottery. That's not exactly similar, but I think you understand. There have been studies that have demonstrated that a lot of the prison population is not terribly healthy, and there probably would not be such a great source of organs for donation. There is a website by prisoners that's really interesting. I can't remember what it's called, but if you're interested in this, you should look it up. But for now, it's the issue of autonomy and capacity that prevents donation from an ethical perspective. But there are some very strong arguments on both sides there.
All right. Thank you, Dr. Reid. Back to you, Dana.
We'd like to once again extend our sincere thanks to Dr. Reid as well as Savitha for your time and for sharing your expertise on this topic. And to all of our participants, we'd like to thank you for your time, and we wish you a wonderful rest of your week. Take care.